So first of all, I would like to welcome you to this webinar that we have together with the ACC cardiovascular imaging section. My name is Julia Grabsa, and I'm the editor-in-chief for JACC case reports. So we are presenting today this online journal club that has the title TAVI Complications and the Role of the Heart Team. And I'm quite pleased to present the panelists. First, I will start with Dr. Lawrence Stratsky, who is my co-moderator for today's session, and he's affiliated with McGill University in Canada. Then the two sets of authors, Dr. Mohammed Kintar and Dr. James Lee from Structural Heart Disease and Department of Cardiology, Henry Ford Health System in Detroit. And then Dr. Helmut Weich and Dr. Philip Herbst from Tykenberg Hospital in Stellenbosch University in Cape Town in South Africa. Also, I want to mention that Dr. James Lee is also representing the ACC Cardiovascular Imaging Leadership Council. And then of course, Professor Ricardo Fontes Carvalho from University of Portland Centro Hospitalar de Gaia, and he's also associate editor for JACC case reports, and Dr. Maurizio Teramaso, Director of Structural Interventions at the University of Zurich, and he's also associate editor for JACC case reports. So after these introductions, I would like to welcome Dr. Kintar, who will present emergency alcohol septal ablation for shock after TAVR, one more option in the toolbox. Dr. Kintar.
Thank you, Dr. Grabsa. My pleasure to be presenting with you guys today. Can you hear me okay?
Yes.
Perfect. So we're going to be brief. We're going to present this case in about 5 minutes. This is a 74-year-old lady who presented to us with worsening dyspnea on exertion, class 3 symptoms. She has a past medical history of coronary artery disease. She had one stent to her RCA in the past. She wears a CPAP at night for obstructive sleep apnea, and she has hypertension and hyperlipidemia. During the workup for her dyspnea on exertion, she got an echocardiogram. Her echocardiogram was difficult in terms of quality despite the use of contrast. However, it was very evident that she had two things. The first thing, on the right side here, you can see an envelope of aortic stenosis with a Vmax of 3.8 meters per second and a mean gradient of 34 and a peak gradient of almost 58 with an aortic valve area of less than 1. However, in the second envelope here in the middle, you can also see that she has an intracavitary gradient of 24 millimeter mercury with a velocity of 2.4 meters per second. So her diagnosis obviously is low flow, low grade aortic stenosis. Just to make sure that we're treating the right thing, we took her to the cath lab and we measured just below the aortic valve, and we got a peak-to-peak gradient of 56 millimeters mercury with a mean gradient of 35 or 34 and an aortic valve area of 0.42, confirming the diagnosis of severe aortic stenosis. If you look at the CT pictures on the left side, you can appreciate the amount of left ventricular hypertrophy and the asymmetrical nature of her interventricular septum. So we proceeded with TAVR, given that she has severe aortic stenosis, she meets criteria for that, and she was symptomatic. And the TAVR portion of the procedure was very, very simple, straightforward. However, right after the TAVR, she went into severe shock. Her blood pressure was like 60 systolic, and we right away did an aortogram. So obviously, when somebody goes into shock after TAVR, you have to rule out a few things. First, are the coronaries filling? And obviously, from this picture, you can pretty much tell that the coronaries are all filling, so that's not the problem. She doesn't have severe AI, and you can see that the TAVR valve is very well positioned and it's not leaking at all. And we don't see any rupture, for example, no annular rupture and no LVOT rupture. So those are pretty much the big ones after TAVR. But she's still in shock. So one more thing to think about, obviously, given the asymmetrical nature of her septum, is a suicide left ventricle or LVOT obstruction. And we did a hemodynamic study right after that. We took that aortogram, and this is what we saw. So just under the aortic valve, she's got a perfect hemodynamics. You can see that she has 0 gradient. So we cured her aortic stenosis. However, when you put the pigtail inside the LV cavity, you can tell that there's a pretty big gradient, and she's got a positive Brockenbrough sign. So after you induce a PVC to the 4th beat on the right side, there's a PVC, and after that there's a massive increase in gradient with decrease in pulse pressure, which diagnoses LVOT obstruction and creates a positive Brockenbrough. So we right away went ahead and took a JL guide, and we took a picture of her coronaries to map if there's any septal perforator that we can use. And in the meantime, what we've done is we've given this patient a lot of fluid. We've given her almost 2 liters of fluid. We started on phenylephrine drip, and we gave her a lot of phenylephrine boluses, and we gave her beta blockers. Those are the 3 things that we can do to treat LVOT obstruction. And despite very aggressive medical therapy, the patient was still in severe shock. So when you are in shock in the cath lab and you need help, you call your expert imager. So Dr. Lee came down to the cath lab and helped us do this with echo guidance. So we selected our septal perforator and we injected into it, and with the help of echocardiography, you can see that we're opacifying the area of the asymmetrical septum in preparation for injecting alcohol. So after we injected alcohol, we can see that the septal perforator is not filling anymore, and the patient had resolution of shock right away. And you can tell this pigtail now is inside the ventricle. It's not below the aortic valve, and you can see that there's 0 gradient despite trying to induce PVCs and trying to see if there's Brockenbrough. And if you can just remember from a few slides ago, when we had a PVC, there was a massive increase in gradient, and here the resolution of shock and the resolution of Brockenbrough, it's a successful alcohol septal ablation. So this is our suggested algorithm for these patients. When you have severe aortic stenosis with asymmetric hypertrophy in their septum, if you have severe shock after TAVR, obviously rule out the main ones: coronary obstruction, perforations, and severe AI. And always think about severe LVOT obstruction when you have asymmetric hypertrophy after you treated the aortic stenosis. And obviously, because you took away the afterload from the severe aortic stenosis, and now they go into a suicide LV. And obviously, the first line is not alcohol septal ablation. The first line is medical management, IV fluids, phenylephrine, and beta blocker. But once in a while, you will need to keep in mind that if those measures are not working, you have to consider emergency alcohol septal ablation as a bailout strategy for treatment of LV suicide causing severe shock. Thank you very much.
Thank you so much, Dr. Kintar. Now I will move to the next case, and I would like to introduce Dr. Weich and Dr. Herbst, who will present dynamic left ventricular outflow tract obstruction post-transcatheter aortic valve replacement. Dr. Weich?
Okay, please go. Hello?
We can hear you, yes.
Can you activate Dr. Herbst's computer? I just got dropped off the call again, unfortunately.
I think Jacob
So,
can...
Luckily, we're down the corridor.
I just ran down to his office.
You should be good now.
Okay,
Right.
excellent, thanks. Let me just share my talk.
Also a reminder to those attending that they can submit their questions to the chat box, and we will address them all after the discussion.
Right, can I just double check you can see that?
Yes, yes, we can see the PowerPoint.
Okay, so I can go. Well, sorry about all the technical glitches, but I think hopefully this will all project well. My name is Helmut Weich. As Julia said, we're from Tygerberg Hospital in Cape Town, and I would like to present quite a complex case of an 81-year-old gentleman who presented to me with significant symptoms of shortness of breath, and this was found to be due to aortic stenosis with a relatively straightforward diagnosis. A pre-op workup showed unobstructed coronaries, and he's got, apart from diabetes, no other medical history of note. He was discussed at our multidisciplinary team and accepted for a transfemoral Edward Sapien TAVI. So I'll show you this. This is the implant, and you can see the valve migrating superiorly during the balloon inflation quite a lot. And here, if one looks at the calcium of the valve, you can see that it's actually above the valve. So there was quite a lot of movement. And here you can see the valve is clearly above the annulus. So we had a problem, and we rapidly prepared a second valve. But as we screened, you could see with the second valve coming up, you can see the first valve had embolized. So we deployed the second one, and I'm showing this because watch during the deployment, there's a lot of, I did the second implant myself, and I pushed quite hard to keep the valve down, but you can see during the balloon expansion, there's a lot of force required to keep it in place down there, and there's still a little bit of movement superiorly. So this second valve functioned well, and then I spent the next hour or so trying to grip the valve with forceps, and eventually I managed to snare it and pull it across the aortic arch. In the interest of time, I won't show all of it. And then in the descending aorta, I ballooned it into position and put a covered stent over it, and it's not a pretty picture, but it was working, and the prosthesis was also working. The next day, his gradient was 14, and there was minimal paravalvular leak, so we were all thankful that he survived the whole ordeal. However, I saw him at 6 weeks, and he said, no, I'm definitely no better, and in fact, I could be even a bit worse, and this is never a good thing when a patient tells you this, and there's a few things to consider. My biggest fear is always endocarditis, and that patients developed a new big paravalvular leak or something like heart block. LV outflow tract obstruction is an unusual complication, and it's in my experience usually SAM related, and the potential causes for this could be that it's an elderly man with a septal bulge. The patient could have hypertrophic cardiomyopathy, and then there's a list of some rare conditions that we don't see that often. And then patient prosthesis mismatch should always be considered, but we looked at the manufacturer's information, and for this valve, the patient should have an effective orifice of 1.2, which essentially ruled out patient prosthesis mismatch as a cause. So obviously we did an echo, prosthesis was working well. There was a small little paravalvular leak, but to my surprise, there was a gradient of 150 millimeters. And you can see this very typical dagger-shaped gradient that we have there with a peak of 150. And if you look at the images we obtained, so here we've got color Doppler, and I think especially on that long post-ventricular ectopic beat, the beat immediately after that, you see there's a flow acceleration below the valve in this sort of area, associated with quite significant MR on that beat. And if you take the color away, it becomes more obvious, especially on that one beat. You can see the SAM, you can see that the anterior leaflet appearing there in contact with the septal bulge. So now back to our differential. I think we can exclude the PVL and the heart block and the PPM. We've talked about those. And the problem is obviously SAM, but I think the question remains whether this patient doesn't have HOCM. Now, I have to apologize. I went back and I tried to find better images but this was a few years ago. And I've got this picture of his LV, and we studied a number of pictures. He has this bulge in his outflow tract, but the rest of his septum and also the free wall, we measured at most 11 millimeters, and even the bulge itself was about 13, 14 at most. So he clearly had no features of hokum, and together with the fact that he's an elderly gentleman, he's got no family history, and it's never been brought up in previous echoes that he's had. So we felt quite confident that he does not have hypertrophic cardiomyopathy. So back to our differential. I think at this stage we can rule out most of the things except for the basal septal bulge as a cause for his problem. So when faced with a problem like this, it's always difficult because there's very little written on the topic, and especially late LV outflow obstruction, most of the cases were people known with hypertrophic cardiomyopathy. And obviously in acute cases, we've just had a very good example of how that could be treated. It's a different scenario to what we were left with. We had a bit more time to decide. Yeah, so him being a frail old man, we started with medical treatment. He did not respond to beta blockade. We considered adding verapamil, but once again, you trying to treat a non-hypertrophic cardiomyopathy patient with hypertrophic cardiomyopathy regimens, which I didn't feel entirely comfortable with. And also the risk of heart block, I think combining those two in an 80-year-old is significant. Disopyramide is unfortunately not available in our institution. So he really did not do any better. And we then had a discussion, what would be the safest step in an elderly gentleman? And we thought that the least invasive and the lowest risk for problems would be a trial of pacing. We don't view the literature as conclusive, but we felt that it's worth trying it because I think the risk was quite low, and there's some data to suggest that CRT might even be better than conventional dual chamber pacing. CRT was attempted. He was pacing his diaphragm, or the lead was unstable. Long story short, that was not, his LV lead was not going to be safely placed. So we opted to just put in a conventional DDD system. With the thoughts, and there's numerous theories about this, but essentially you're inducing dysynchrony, so you're inducing contraction of the lateral wall at a time when the septum is not contracting, and then the septum contracts later. So the dysynchrony together with the reduced contractility hopefully would open up his outflow tract. And so we programmed it with echo to shortest AV delay that we felt did not interfere with LV filling. And I've got a picture here of literally on the, while we're programming the pacemaker, this is pacing off, this is pacing on, and that's pacing off again, and that's pacing on again. So we had a very good result with pacing, and 2 years later his gradients remain low, and I've even exercised him to see if we can induce any abnormalities, and he's doing well. So we were very happy with the results. Thank you.
That's great. Thanks. We've seen two very interesting cases of LVOT obstruction post-TAVI, and you think that was commonplace. It actually isn't. But the septal bulge and LVH actually is commonplace in patients with who are going for TAVI. Ultimately, the cases were managed by established non-pharmacologic methods, septal ablation, RV pacing. We have a lot of tools in our armamentarium. Of course, the acute we heard about in terms of volume, beta blockers, phenylephrine, drip. And when they fail, obviously you need a mechanical solution. And we saw a case of septal ablation, another one of pacing. So it raises a number of questions as pertains to management. First of all, why do we get SAM post-TAVI? What are the anatomic and physiologic features that cause this? And is there any way to anticipate this? What might we want to measure on echo or CT or even MRI? So now we're going to hear from Dr. Grapsa and Dr. Lee, who will address some of these questions, what we look for in TAVI in terms of complications and the utility of CT in TAVI.
Thank you very much, Lawrence, and I agree with you that these cases are very interesting in order to help us understanding how imaging, and the role of heart team may prevent these complications. So on the next slide, you will see it's just a brief overview of what may happen during implantation of TAVR. And there are several papers employing not only transfemoral TAVR, but several different techniques and, of course, individualized approaches. But the most common problems would be, of course, vascular access, conductional disturbances, as they were mentioned also by Dr. Weich, coronary occlusion, the landing zone rupture, and stroke. During the implantation, we see very often a paravalvular leak, and we need to assess the degree of that. And of course, for us as imagers to make sure that it's not hemodynamically important for the patient, and together with the interventionist to assess, of course, whether it needs to be closed or, of course, for the valve to be adjusted. Then, of course, the aortic rupture, LVOT obstruction, and device embolization that may take place if there is not enough landing zone. But then on the next slide, also coronary complications are now have decreased rates with new generation devices, and it's important to protect the coronary ostia during valve implantation. And that's a very interesting paper from last year from JACC Interventions, how to prevent actually coronary obstruction during TAVR. And my last slide, which is the next one, is I found very interesting the big 5 complications after the TAVI, and whether we need to be afraid of them. And Dr. Lee will give us an answer on how peri-procedural imaging is important for, of course, we have paravalvular leak and renal dysfunction, rhythm disturbances like block, bleeding, and stroke. So with this, I will give the word to Dr. Lee and his presentation. Thank you.
Hi, Dr. Grapsa. Thank you so much for that kind introduction and that great overview. I'm going to share my slides here. So I'm going to talk briefly on CT planning for TAVR. And so TAVR has been quite revolutionized by the utilization of CT, and echocardiography is still quite important for TAVR, but largely at this point remains in the realm of confirming the diagnosis of severe aortic stenosis, as well as identifying a number of the low gradient variants. But CT really plays a front and center in identifying the optimal vascular access route, as well as some of the additional risks of valve implantation and helping with valve sizing. One of the main things that we learned from CT is that the aortic annulus, which was initially felt to be circular, is actually an oval structure. And transthoracic echo and transesophageal echo, both from a 2D plane, oftentimes gets the shorter of the 2 dimensions, which may explain some of the higher PVL rates in the early TAVR trials. And the aortic annulus is not a physical structure, but really a virtual plane at the bottom insertion points of all 3 aortic cusps. Now, the actual way to measure the aortic annulus for valve sizing will depend on the actual manufacturer being used, but the techniques generally are looking at the aortic valve area, aortic valve perimeter, and aortic valve dimensions, and there's a number of formulas that you can use to help size the valve. But there is some evidence to show that using CT for valve sizing does improve the degree of paravalvular leak post-TAVR. CT also allows us to look for calcium distribution on the aortic valve leaflets and aortic calcification in other parts of the aortoannular complex, including the aortic annulus and LVOT. And the risks of calcification can include coronary obstruction, as noted, conduction system injury, annular rupture, and paravalvular aortic regurgitation. Interestingly, inadequate calcification can actually increase the risk of complications such as valve migration and valve embolization. So some degree of calcification can be helpful. One of the other things that we look for in TAVR's planning is to look for coronary heights, as below coronary heights, generally under 10 millimeters, is the highest risk for coronary obstruction. And you can see an example of that on the cath image on the right. The increasing use of valve-in-valve TAVRs predicting coronary obstruction continues to be growing in importance, particularly in surgical aortic valves, where the valves are oftentimes surgically implanted higher than the native annulus. CT also allows us to use dynamic imaging to look at valve morphology, such as the tricuspid leak on the left with aortic stenosis, the Sievers class 0 bicuspid valve in the center, and the Sievers class 1 bicuspid valve on the right. There's been a lot of interest lately in using aortic valve calcium scoring, basically taking the Agatston score used for coronary artery calcification to predict whether a low gradient variant of aortic stenosis is truly severe or whether it may not be severe. You'll find a number of cutoffs recommended in the literature. These are the cutoffs proposed by the 2019 SCCT guidelines. Now, you do need to have some caution in using this technique, particularly in younger patients who may not have a lot of calcification yet, and in those with bicuspid valves who could have significant stenosis without a lot of calcification. Now, we spend a lot of time actually using the visual appearance of the valve itself to see, in these cases, oftentimes you'll find, particularly in very obese patients where the stroke volume index and echocardiography may be quite low, the valve actually has quite good mobility. So I think it's important not only to use things like the aortic valve calcium scoring and your echocardiography techniques, but all your tools in the toolbox to really establish your diagnosis. We'll find some additional procedural impediments can be identified from CT, including calcification at the sinotubular junction, which could rupture the balloon during valve implantation. Things such as a prosthetic valve in the mitral position, and TAVR valves can impinge on the mitral valve, leak the function, both valve prosthetic and mechanical, as well as impede the aquial landing zone of the TAVR valve. And issues such as mid-cavitary obstruction or LVOT obstruction, as noted in the NICE cases previously. CT also allows us to find additional procedural risks such as left atrial appendage thrombus. And this can be seen in a fair number of patients. And you can actually, most of the techniques for CT for TAVR planning were developed for coronary CTA, and in appropriate patients, you can oftentimes exclude obstructive coronary disease, such as this patient. Although many patients will be like this, where you can see there's extensive calcification and coronary disease that really precludes you from excluding disease. CT also allows you to plan things like fluoroscopy C-arm angles, reducing the procedural time and contrast use during the procedure itself. The other main role of CT is to identify the safest vascular access route, and femoral access is the most common and most desired route when feasible. Certainly, there's many patients out there with extensive peripheral vascular disease, such as this patient, where femoral access is less than ideal. In these patients, you may plan carotid access, axillary access, and less commonly these days now is a direct apical access. And then institutions such as ours, we tend to use a lot of transcaval access, where we use electrocautery to go from the vein, IVC, through to the aorta. But this is done mostly in specialized centers. So in addition to looking at sizing, when you look at vascular access, you want to find other procedural risks such as aortic aneurysms, aortic dissections, and not only this dissection, but the kinking of that vessel, which may preclude the catheter from migrating through this vessel, even if you are able to wire past it. Here's an example of a patient that had an endovascular stent in the abdominal aorta, which had adequate sizing for a delivery sheath. But due to a stent in the right limb of the endograft, actually the operators had quite a lot of difficulty getting that delivery sheath through. And so you really need to take a holistic approach at the entire aortoannular complex for valve delivery, valve sizing, and for peripheral vasculature, all the potential risks from sizing, tortuosity, and other impediments. Thank you.
So thank you so much, Dr. Lee. Now we can start the questions, and we have a question from the audience. Lawrence, I hope it's okay to address that maybe to Dr. Weich. Which dynamic LVOT obstruction patients are okay to go ahead with beta blocker post-TAVR without requiring ablation or pacing? Actually, the question is open. So who would like to answer?
I must say, I think it depends on the clinical picture of the patient. I think if they are stable and the symptom is that of shortness of breath or tiredness, I think I would certainly start with a beta blocker and give that a go. It could be as simple as that, and you might not need to do anything else. Yeah, in all patients who are stable, I would consider that the first line.
Any dissenters?
I may make a comment. I think it's totally important to focus the treatment on the patient, obviously. But now let's say that LVOT obstruction after TAVI, it's really uncommon. It may happen. We should know how to deal with it, but it's really uncommon. What is quite common and is emerging more and more is LVOT obstruction after TMVI, so transcatheter mitral valve implantation, which has somehow different mechanism, but the management could be the same. And this is after valve in ring, or even after native replacement. And there are some data telling that after TMVI, there is a clear cutoff. If I remember, is 30 of mean gradient in the LVOT. And this is discriminating really well the mortality at 1 year. So I think symptoms and patient profile is important, but if we want to give a kind of number, I would say that 30 is the threshold that we should not accept. And if with the medical treatment we cannot reduce below this cutoff, which is quite high, then when we should consider alcohol ablation or pacing or anything else.
So Dr. Taramasso has the first question, but I just want to make a comment on that in terms of there's an earlier study many years ago looking at the day-to-day variability in terms of LVOT gradient. So a 30 on one day could be a 50 the next day, could be a 15 the following day. So I wouldn't necessarily act on a single study, but a single result. So my question to you, Maurizio, is as a structural interventionalist, what is your advice to avoid LVOT obstruction during valve positioning? Are there things that you look out for when you're reviewing your images in your multidisciplinary rounds, when you're reviewing the echo, when you're reviewing the CT? Is it pre-existing SAM? Is it a pre-existing small LVOT gradient? Is it marked septal hypertrophy? How do you think about it, and how does that affect your planning?
Yeah, actually, you look at all these elements. I have to say it's really, really difficult to predict. There is not only one parameter. If you look at the CT of the first cases, it was quite impressive, the amount of hypertrophy. So this is really indicative of this kind of risk. But still, I think I would not reject a case based on this anatomy. Obviously, you should be ready to have a bailout strategy as they did. But it's really, really unpredictable. This specific complication, I would say, is really rare. I think, I mean, I've done more than 1,000 TAVI, and I've seen this really less than 5 times, probably. But nevertheless, could be really disruptive, and we should keep in mind that it may happen, and we should keep in mind how to deal with. But you can identify patients at risk, but it's really, I mean, in my opinion, almost impossible to predict because it's such a rare complication based on multi-factor elements that, so you look at the element that you mentioned, but there is not one which is prevalent on the other one.
Thank you so much, Maurizio. Now it's my turn actually to ask Ricardo. Ricardo, what do you think about, as an imager, to measure the orifice effective area of aortic valve with 3D when we're using the new softwares and maybe the 3D color Doppler? And also, do you trust mostly the continuity or the gradients? And also, if you can transfer us the experience, from your lab, do you trust mostly echo or you do a CT always in these cases? For example, the main point is how do you deal with a visually severe AS? We have many times in my lab, we say visually it's severe or tight AS, but the gradients do not match.
Mm-hmm. Okay. Yeah, fantastic questions. Hi, everybody. Nice to be here with all of you. We could be doing an extra webinar with all these questions and with all these difficulties that we sometimes have in our clinical practice. I would start with a general principle of echocardiography, and I would say a general principle of in medicine, which is in medicine, I would say that there are no magical numbers, there are no magical parameters, and there are no magical techniques. And I think the secret for the clinical practice is a good integration of the several parameters that we have, a good integration with the clinical status of the patient, and of course, to understand very well the advantages and the limitations of each technique and of each parameter. That being said, and regarding your question about the role of 3D in the assessment of the orifice effective area, we know that 3D echo has completely changed the way on how we do echo, and this applies also to the use of the echo, not only to assess the severity of aortic stenosis, but I will say also in the assessment and in the planning for the TAVR. And regarding what you said, we know that the planimetry of the orifice area of the aortic valve in TAVI can be assessed with a high quality color-coded echo 3D or 4D data set, and it is possible to make a good planimetry of the systolic jet area, mainly if you do it perpendicular, of course, to the main jet direction, using these techniques and with the post-processing software, for instance, QLab, but also EchoPact. What we need to understand is that these techniques and the use of this 3D and also the integration of color Doppler in this planimetry has some limitations. We still have problems with the temporal and also with the spatial resolution. What we can recommend is some small tips and tricks to increase the accuracy of this, which is mainly to use higher frequencies to get sharper contours of the color flow, and also to use the zoom function to increase the volume rate. And this, with these small techniques, sometimes we can improve our capacity to better delineate the planimetry of the aortic valve. So this sometimes is helpful in these kind of situations that you said, which happen frequently, when you have discrepancy between the gradients and what we have in the continuity equation. There are a lot of things that we could talk about the discrepancy between the continuity equation and the planimetry. We must never forget it is important to look at the LV function. We never forget to look at the methodological errors. Don't forget to look to the flow conditions and the heart rate. Don't forget to look to the stroke volume. But in this kind of situations, when you have a discrepancy between parameters, I think we should look at all the parameters at the same time. And sometimes it is useful, as Dr. Lee also stressed, when you have some doubts, and we do this in our clinical practice. For instance, sometimes it's useful to use the calcium score of the aortic valve to have another technique and another kind of information to look at this. That being said, all of this, and going to your last question, what we do in our clinical practice, when now what we are doing in the planning of the TAVR procedure, if we go more for the echo, or if we go more to the CT, we start with the echo, with the transthoracic echo, of course. When we have doubts, and not always, we go to the transesophageal echo, but we are now, and we changed in the last 6 months, our protocol to sometimes usually avoid the transesophageal and trust more in the CT information. Because, as Dr. Lee said, I think echo is very important to assess the function and to assess the severity, to look at the LV function. But then when you go to the planning, there are some extra information that sometimes you only get with the CT. Although I usually trust also in 3D echo, I think 3D echo, we should not skip the 3D echo. 3D echo is important, especially the transesophageal 3D echo. We are using more and more the CT, and I think this is a worldwide thing that is happening. So to conclude, never forget to integrate all the information coming from the different techniques. When you need to assess the severity, trust more in the echo parameters and integrate all the echo parameters. And then when we decide to go to TAVR, then go to the CT for this correct planning and to reduce the risk of complications. So this is more or less what we do in our clinical practice in our center.
Thanks, Ricardo. Now to James Lee. we're heading towards a theme of integration. We hear a lot about the routine, how we routinely use echo, more echo when a patient has, for example, chronic kidney disease, when we can't give contrast for our CT planning. So we do a lot of 3D for measurements. We do transesophageal echo for guidance to minimize contrast. We heard about the first case, Dr. Kintar's case, where there was poor image quality on the echo. So the question is, when should we use CT as the primary imaging modality to supplement echo beyond the calcium score? If we saw the CT showed significant upper septal hypertrophy, when you're reading out the study, what do you report? Do you report all these things as opposed to just the calcium score and the anatomic findings related to the LVOT and the valve and the vascular components? Would you be more likely to report out all additional details if you were told that the CT was of suboptimal quality?
Yeah, these are great points, and all the other speakers really are touching on this theme of integration and picking the best tool for the best job. We rely very, very heavily on CT at our institution, to the point that it's actually very rare that we can't actually get a CT on a patient. We maybe turn down one patient a year out of a large high-volume center. And we reduce the risk of this with a hydration protocol pre-procedural, and we've really not had any acute kidney injury, even in folks with a pretty significant chronic kidney disease. And you know, if you do come to a case where you really can't use CT, then your local expertise is going to determine, I think, the next best option. There are certainly centers with a lot of expertise in cardiac MRI and valve sizing that have successfully done some valve sizing at that time using 3D data sets and cine imaging. And certainly many people are very facile with the 3D data sets and QLab to do valve sizing as well. We personally at our institution, we try to avoid that if at all possible, but certainly has been done. Regarding the other issues, you know, we actually do comprehensive evaluations on our CTs. We probably provide about 50 to 60 individualized measurements, which may be a little more than a lot of centers. Interesting one that we do not provide is a specific basal septal measurement, but that may be something that we consider to integrate in the future, given that we see all these cases. You know, but to the point that was brought up earlier, that this is quite a rare complication, right? So we actually see very routinely folks with mid-cavitary obstruction, hyperdynamic function, and don't see this LVOT obstruction. And so even though in our multidisciplinary conference, when we see these things on the dynamic CTs when we're reviewing with the group, we alert them to this, but we don't necessarily turn down cases because of this. But it just gives the whole group, you know, that mindset of this is something that we need to keep top of mind if we do see some hemodynamic instability post valve implantation. There's, I guess, some question about, you know, between the modalities. It's important to validate every measurement you're using on every modality. You know, just because of spatial resolution concerns, the annulus is generally going to be systematically lower in size when measured on echo compared to CT, even when using 3D TEE. And even with some of these other things where we're talking about aortic valve planimetry, I think these are all good tools to have in your toolbox. But there was an interesting study done probably about 5 years ago now where they used the CT annular area and plugged it into the continuity equation and routinely got calculated aortic valve areas that were systematically higher than the echo-derived valve areas. And so we can't just take each of these tools and plug them in without doing the validation of what the outcomes are for this. And this is why, even though we don't use a lot of the aortic valve calcium scoring at our institution, I think that the fact that the folks that do use it a lot took the step to take the tool and validate it from an outcome standpoint is actually a very powerful, set of information.
Thank you so much, Dr. Lee. We will move to Dr. Kintar. So in many sites, you know, we have now TAVR performed with conscious sedation and transthoracic echo. And for example, in my institution, we use a lot CT scan. Every patient is having a CT TAVI, and we do not use TE at all. What do you think about TAVI procedures with no TE monitoring, particularly when you have a complication like the one that you mentioned? Do you routinely have a TE probe placed when complications arise?
That's a very good question, and I think in the earlier days of TAVI, and even in some programs actually right now in the United States, they're still performing every TAVR with TE. Now, having been trained at a high volume center, I think the TEE question, it does provide a lot of information when a complication happens. Take, for example, our case for today. We didn't need a TE. All we needed is a transthoracic echocardiography to guide our alcohol septal ablation. Now, if the case was different, let's say the patient is having some sort of an unusual fistula or unusual perforation, I think in that case, probably a TE probe would be very, very helpful. We've had a case where we had an aorta RV fistula, and if you wanted to close that, or if you wanted to kind of diagnose it even better, you would probably need a TE with a comprehensive evaluation. So in summary, I would say that most of the complications you would not need a TE for, but I think once you have a diagnosis, or if you're struggling to have a diagnosis, I think a TE probe is not a bad idea.
Thanks, Dr. Weish. Your case, the images are very interesting. You pointed out that on the post-PVC beat, the echocardiographic equivalent to the Brockenborough-Brunwald phenomenon, where you saw the impressive SAM both on 2D and the LVOT acceleration and the SAM-related mitral regurgitation. But on the beat before, or the PVC beat, not the post-PVC beat, there actually was very little SAM, if any, and very little outflow tract obstruction by color Doppler. We had heard that one of the mechanisms of pacing is to reduce dysynchrony. Did that factor in? And is that something that perhaps we should look for? In your case, in your patient, we had the luxury of not being an acute situation, but we hear about responders, non-responders. Is that something that we should look for in deciding whether to use pacing to treat these patients?
Now that's very well spotted. I don't think anyone else picked that up, but it's certainly so. I had a good look at it, and it is the case that on that PVC beat there wasn't SAM and there wasn't acceleration in the outflow tract. Obviously, our approach was a bit more philosophical in selecting pacing for this patient. In fact, the initial plan was to put in a temporary pacemaker and just see what happens and make a decision on the table after doing that. But we were still unsure after doing that. But I think it's a valid point. I think if you have the luxury of catching a PVC and it shows that you don't have the features of outflow tract obstruction, it is potentially something that might push you towards doing going ahead with the pacing. But I think, these are elderly patients. They often frail. I think something like alcohol septal ablation, unless it's done in a very high volume center by experts, it's a procedure not without risk. And I would maintain that for us, and in most cases where you're faced with this, pacing would be a good strategy as a first step in many patients to see the response and safe.
Thank you so much, Dr. Weich. That's really interesting. And I need to move now to Ricardo again. Ricardo, when a patient is hypotensive after a valve replacement, LVOT obstruction is not usually at the top of the list of causes. Do you have an imaging approach such as like pericardial tamponade at first, or do you have like a protocol that you look for tamponade at first, then coronary ostial occlusion? So how do you deal with that in terms of imaging?
That is a very good question. As Maurizio already said, actually, this is not the kind of cases that we see every day, the LVOT obstruction in TAVI. Usually, when you have a patient with hypertension, you look for other causes. You told the big five, but in the big five, there are at least two that could be responsible for this kind of hypotensive patient. What I think it is important in going again to this discussion of using or not TOE during TAVR, I think that nowadays with the new techniques and more experience, it is not, I think TOE is not a standard approach and should not be used in general. But you should have the echo inside the lab to, in case there is any kind of complication, immediately turn on the echo and look at least for a general echoscopy, as we usually say, to understand what is happening to the patient. So I think that most of the times we can have a good, during the procedure, we can easily understand what is going on, but it's important that someone in the room, or at least someone who is very near the room, can go immediately to the lab and to perform this POCUS, I would say, assessment with the echo, just to understand what is happening. And if in the transthoracic echo, you are not understanding exactly what is going on, start looking if there is pericardial tamponade. Look if there is any kind of wall motion abnormalities. Look to the general LV function. If you are not understanding, then insert the TOE probe. But I think that most of the cases, you can easily understand what is going on actually with the transthoracic echo, which can be performed like this kind of approach. When you have a complication, have immediately the echo. And more, we are using, for instance, in our department, the echo to guide the puncture in the femoral artery. So the echo usually is in the lab, inside the lab. So sometimes it is quite easy, and all the cardiologists should do this, which is look to the transthoracic echo and start to understand. If they have doubts, call the imaging expert to help us to solve the problem.
So I just want to make a little quick comment that we often forget about in terms of causes of hypotension or patients not doing well, intra-TAVI, post-TAVI, and that is the inducing of dysynchrony. We have a lot of patients where, you know, they're in narrow complex and normal sinus rhythm and their LV looks great. They develop a bundle block and their LV looks terrible. So that can be something that you really should look for and see if you can explain it as one of the causes of hypotension. We have people going in and out, and we see the blood pressure going from 110 to 80 to 110 to 80, depending on whether they have a bundle branch block or not.
I agree. And you can also understand with the echo. Echo will, and if you correlate with the EKG, it is easy to understand this also, which is a good point.
Thank you so much, both. As a last question to Maurizio, Maurizio, as you know, structural interventionalist, and of course cardiac surgeon, when you see a big calcified spackle on the CT in the LVOT, or a big septal bulge on echo or CT, first of all, are you worried? And are you worried, or how are you going to place your valve? What are you thinking at the time?
It's pretty much variable on several aspects. For example, now we are moving more and more towards lower risk patient. In my opinion, this is an argument to say that CT scan is mandatory before all TAVI, unless there are specific situations like severe renal dysfunction. But I think in 2021, do a TAVI without a CT scan in absence of a clinical reason is just wrong. Because from CT, we have some anatomy that we know that are not good anatomy for TAVI, and then we can reconsider the surgical indication if the surgical risk is low. For example, big asymmetric calcification in the LVOT, or really calcific bicuspid. I mean, there are some, from CT, we can really predict if this is a good candidate for TAVI or not. And this is most important for low risk, because if the patient is at high risk, obviously we accept also suboptimal anatomy. Then it is important also the location of the calcification, not only the amount of calcium. There are some locations which are, let's say, more dangerous, because, for example, if you have a calcification below the left main, if you have a rupture there, you will have free bleeding in the pericardium, so you will have free annular rupture. If you have it in the septum, you may have VSD, which is also a bad complication, but let's say maybe less tremendous, at least acutely. Then you may have a risk of pacemaker. According to the location, you can also somehow predict what may happen. And then if you have heavily calcific LVOT, I think that also the choice of the valve rather than how to position the valve. Obviously, if you have a patient which is at high risk for pacemaker, you will tend to implant higher, which should be always the aim with some valve, and probably to prefer self-expandable valve. If you have a risk of annular rupture, you may, you should probably accept a compromise between paravalvular leak and risk of annular rupture, but I think it's still, if the calcification are massive, safer to go for a self-expandable valve. So all this information are important in deciding not only whether to go for TAVI or rather reconsider surgical indication, but also which type of valve to implant.
Okay, we actually have one more question from the audience, and I'm going to make one other comment. The question is, can we predict the LVOT obstruction after TAVR? That's actually what we've been trying to do for the past nearly 1 hour, and the conclusion is no, we can't. We can't predict it because people haven't really concentrated on why it happens and have actually thought about this problem, and hopefully this webinar has given people the impetus to start thinking about it. If I see, like on the first Dr. Kintar's contrast-enhanced picture, there was the anterolateral papillary muscle was more apically displaced. If I could have seen the leaflets, if I see the septal bulge, if I start seeing things that make me think that perhaps this patient may have hypertrophic cardiomyopathy, or if there's a marked hypertrophy, then it would get me thinking. Now, can we prevent it? It doesn't sound like it, but also because we haven't thought about how to prevent it. I just want to make a comment about Dr. Weich's his comment about alcohol septal ablation. It's a challenging thing. There's a learning curve, etc. I just want to introduce some new technology that our site developed and actually just released this week in partnership with one of the major TAVR manufacturers and a local engineering group in Quebec called Auger, where we link together the Microsoft HoloLens together with simultaneous live digital feeds from our fluoroscopy, our hemodynamics, our echo, bird's eye view of the room if necessary, and that can be transmitted in real time just via a phone call pretty much, and someone with an appropriate connection, soon to be just via a glasses type setup, but right now on 3 monitors. Can be sent anywhere in the world, and someone can actually not physically, but virtually be in the room guiding the person. So if this technology were in place, for example, and you needed to do an emergency alcohol septal ablation, is something that could be potentially feasible in someone who's seen one or done one, to have an extra helping hand. So there actually is help available for those who ask. So I just want to close the session by thanking all the speakers. Really, we have a great international panel of experts and people who actually do this stuff. And the audience, we had nearly 100 participants. There are many more who registered, and this is going to be available online through the ACC website within a couple of days. You would go to the ACC Education's meeting homepage and go to the On Demand tab. We're looking at putting a link to all our previous sessions and linking to key references eventually on the imaging section webpage. So on behalf of Julie Grapsa and myself and all the ACC staff who've been great in planning this, I want to wish you a fantastic day and a great summer, and look forward to holding this another session in the early fall. Please stay tuned. Thank you.
Thank you, everybody. Thanks.
Thanks, everybody. Bye-bye.